Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, I'm David Kaufman here with my colleague and friend,
Eileen Ruhoy,
for another episode. I totally have lost count. I have no idea how many we've done now. It seems like a lot, though.
Somebody counted actually for us.
Yeah.
Did you see that on the Patreon page?
Yeah, but I already don't remember the number. Anyhow, so we had some very good suggestions and questions in the last after the last episode, and we're going to take off with those. So the first thing we're going to talk about today is, in shorthand, Ehlers-Danlos syndrome and the immune system, which is about a topic as big as this room.
As expansive as
Right.
this space.
Right.
Yeah, it's a big topic, and I think it's an important topic, right?
It is
Because
so important.
I know, because all of our EDS patients have some form of immune dysregulation. And it doesn't fall into the camp of immunosuppression or immunocompromise or even necessarily an autoimmune disease, right? So it's an interesting autoimmune problem that I think we should preface this by saying we don't completely understand.
Right.
And we don't have all of the, gritty details of it. But we've worked with enough patients
Right.
to sort of get a sense of what's going on and what we can do about it.
Yeah, and what grabbed me about the topic suggestion is I actually much prefer the term connective tissue disorder or connective tissue disease or connective tissue problems,
Right.
because I feel it's important that part of the discussion is addressing the fact that you don't have to have EDS to end up with a connective tissue disorder as a result of immune disturbances and other inflammatory issues.
Right. And I think that, we've talked often, you and I, about, not necessarily on
Yeah.
the podcast, but how this EDS labels sort of, we're not exactly sure if that's what we should be calling it.
Exactly.
Right? So it's
exactly.
it's sort of an interesting, but we know there's a connective tissue component to these septet patients that
Right.
we regularly see. And it's weird that we say EDS. And I know we all do it, including us. And I think it's because then we all know what we're talking about. But I think it's a lot more complicated than just calling it Ehlers-Danlos
Well,
syndrome.
yeah, it's like when I use the term POTS,
Right.
I'm using it very loosely. I can be easily criticized because it's not orthostatic hypotension or hypertension. I just say POTS because it just makes the conversation easier,
Right.
and then we take off from there.
Right, because everyone knows what you're saying,
Right.
and so, right, but it doesn't explain a lot of the other autonomic
Right.
symptoms that patients have, but
Exactly.
other than the tachycardia. So, yeah. But the immune system in EDS, so the immune system is almost always, if always, affected in connective tissue disorder patients. And, the reason for that is probably multifactorial and probably lots of reasons, but we do know that there's a lot of immune activity that takes place within the connective tissue. In fact, there are immune cells, there are antigen-presenting cells. So maybe we should explain what that is.
Go ahead.
So in our immune system, when, let's say, we're exposed, when we have an infection, the pathogen is sort of broken down, and pieces of that pathogen are taken up by certain cells that have a function to present those pieces of the pathogen, and they present them to immune cells, and those immune cells recognize them for what they are, which is something that should not be there, basically, and then they mount an immune response.
Right.
And that there are several different types of immune responses, of course. Autoantibodies, there's cytotoxic cells that will just destroy that cell that's holding that piece of the pathogen. But so there's antigen presentation is what we refer to as, an antigen, of course, being what provokes the immune system. And that does take place within the connective tissue. There is antigen presentation within the connective tissue.
Yeah, I like to think of it as Pac-Men. Right? So little Pac-Men go around and they take little pieces of the antigen, they bring it back to the mothership or home base or the lymph node, present it to the immune cells, and then the whole cascade begins.
Right, and that cascade is, I remember just learning immunology in medical school and just being completely fascinated.
Yeah.
I'm not sure why I didn't go into immunology. I wish I had.
Yeah.
Because it really is.
It's-
I think
it's
everything starts
incredible.
with the immune system, right?
Right.
And I think, it's yesterday with a patient, I was having the conversation of, this patient who's been chronically ill for many, many years and just was found to test positive on several different, had a whole panel of tick-borne disease. I mean, in fact, you know this patient, tick-borne diseases, and everything was positive. But also has had a long history of testing positive for autoimmunity, for different autoantibodies. And so we were having this conversation, they were being told that they should both treat the infection, but also others were saying you should treat the autoimmunity. And sort of the question to me was, what's my opinion? And I don't really know the right answer. And I was obviously transparent and honest, but I'm curious. Like, I know we always do this. Now I'm off topic again. But I was just sort of thinking about, how our bodies, how the immune system is such at the core of everything that I think happens to us in many respects. And it starts with, of course, the challenge, the assault on our bodies from some sort of exposure. Again, we're referring right now to infectious exposures, but there are others. And so in that kind of case, I'm just sort of curious, like, what is your thought? Do you treat the infection first? Do you treat the immune response? Or do you do both at the same time?
Yeah,
or do you not want to answer that
no,
right
I
now?
do want to answer it, but I just want to warn you and everybody, we're going to go way off topic here. And ironically, we're going to come to the issue you and I were discussing on the stairs as we were coming up about that paper, which you haven't read yet. So I'm going to not
read it.
name the paper.
We're going to do that paper.
We're going to do this paper.
Yeah.
But going for, okay, so reset. Obviously, it depends on what kind of labs, okay?
Okay.
So when you say, or when one says autoimmunity, are we saying an ANA that's positive, which is kind of a screening test? Or are you saying, is one saying that their Sjogren's panel was very, very positive and they had symptoms consistent with Sjogren's disease? So it's a bit of a tough call. I do think, even though I don't agree fully with this paper, I do think that in our patients, whether they have mast cell activation syndrome and or active infection, that provokes other autoantibodies. And in fact, and we've talked about this before, if you look at the history of rheumatology, it was pretty clear back before all the biologics and fancy expensive drugs that infections were the cause of autoimmune diseases. So it makes sense then that means that they cause the production of autoantibodies, so-called mimicking antibodies, different from the mast cell mimicking antibodies that are being discussed in that paper, that cause disease. And a classic example would be pandas. Another classic example is rheumatic heart disease, chorea, Sydenham's chorea, kidney failure, all from strep infection. So you can't ignore those autoantibodies, but you're not going to fix them unless you get rid of the strep. That's kind of what I'm trying to say. So it's a question of sorting out the antibodies, the clinical significance of the antibodies to make a decision which you go after first.
But if they're symptomatic from that autoimmune
you still
process,
have to do something.
But do you do that? Do you treat it first and then treat the infection?
Well,
do you do it both at the same time?
Such
do you
a
treat
critical question. I agree.
I know.
So my answer would be sort of, meaning in that kind of patient, in that situation, I'm not going to give an immunosuppressive drug for the autoimmune disease if they have an active infection. And to be really clear, that dilemma plagues me almost every day of the week with certain patients. I have patients who have clear-cut active infection but clear-cut raging autoimmune disease, such that they're getting IVIG and plasmapheresis and consideration for Rituxan, but that infection just haunts me because it's still there. And if I suppress their already crappy immune system because that's their situation, what's going to happen? I think it will be a bad scene. So it is a problem to wrestle with all the time.
And is there a contraindication, in your opinion, to use immunosuppressants along with antibiotics?
I wouldn't say it's a contraindication, but I'll be darn careful.
Yeah. Okay. Okay. It's just an interesting, because this is obviously most of our patients are connective tissue patients. And so this is the one thing that I always get concerned about, like what will not further degrade the connective tissue, right? So that's what I'm always playing with.
Right. So let's pull back a little bit.
Let's go back to the
good
original
segue.
topic.
No, it's a good segue to it. The autoimmune phenomena and the infection phenomena are causing inflammation, and it's the inflammation that's degrading connective tissue. Right? And that brings us back to what we said at the very beginning, which is You don't have to have EDS to get messed up connective tissue if you have chronic long-standing inflammation.
Right.
If you have EDS and chronic long-standing inflammation, it's obviously a potentially worse situation, and all the more compelling reasons to deal with the causes for that inflammation.
Right, absolutely. Because even speaking of the mast cells, and we know that, some of these immune cells release mediators such as proteases that further break down connective tissue. So it just sort of makes a problem that much worse.
Right.
And it's interesting that I think patients seem to stratify into different groups with regards to the severity of the connective tissue component. And certainly many of them don't give a very strong history of being hypermobile early in life. Right. In fact, some will say, no, I was the least flexible of my group. And in fact, many of those will give a history, though, of lots of infections, mononucleosis that took me out for several months and I missed school, or recurrent strep throats, weird diarrheal illnesses, or, exotic travels. I went to, these countries and I got this kind of illness, or multiple concussions, actually. It's interesting how many patients I have who give me a history of, 4, 5, 6, 7 concussions and TBIs, and then I worry about the cranial cervical instability, right? So, because they give symptoms of that from just these multiple concussions, and just as a side note, like I start to think about CTE, and I wonder how many of those football players have CCI, right?
Right.
So anyway.
I think their CTE trumps their CCI, though, unfortunately for them.
Well, at that point, yeah. But I'm saying early on, someone maybe
agree.
recognized the cranial cervical instability that was compressing every part of that anatomy of the cranial cervical joint, I wonder what could have been prevented, if anything at all. I mean, these are just thoughts that keep me awake at night.
Why would we do anything about that? We can't do anything about football. I mean, we could ban football, but
no, I know.
Then we'd be probably thrown in American jail or something.
Don't
get me started.
So I think that so it's just interesting that there are all these different camps of patients that you try to make sense out of, but the truth is there isn't a generalization that could be made necessarily. The only generalizations that we can make are what we know about the anatomy and the physiology of the anatomy, right? So as we've talked about, there's a lot of immune activity that takes place within the connective tissue.
I think there are some generalizations we can make.
Okay.
And they apply to our patients in this situation with EDS or not EDS, but I think the power of the generalization is before they get to be our patients. In other words, if we're correct that inflammation is a driver of progressive connective tissue disorder, and if that driver is more dangerous, or whatever word to use, in a patient with pre-existing connective tissue disorder, i.e. EDS patients, then clearly, as an overall generalization, anything we can do for our current patients to treat and reduce, erase, get rid of inflammation will be potentially valuable both immediately and long-term.
Mm-hmm.
That's a mouthful, and it's not easy, and I don't propose to suggest that, it's no big deal, just do it. That's not that easy.
Right.
Okay. But the other part of the generalization to me is I have a patient sitting in front of me, and that person has two children, and I'm sort of at the point where even though they're not my patients, I will ask for more information about their children, because if there's a suggestion of frequent infections or connective tissue disorder, I'm going to say you need to start dealing with it now before they get to be like you.
Right.
And that's tough for patients to hear, but I think it's kind of our responsibility. I mean, that doesn't mean I'm going to take their children as patients, but it does mean if they're seeing doctors who say, don't worry about it, 9 infections in 1 year is no big deal, move on, We need to deal with chronic recurrent infections and inflammation that comes from those infections, as well as other things that cause it. And bringing it back to EDS for a second, so think about the patients that you and I see that don't know they have EDS or hypermobility syndrome, whatever. Again, the terminology drives me nuts. And they say, I was fine until I got mono, and then you take a history, and they say, well, when I was growing up, I had growing pains. Everybody said, don't worry about it. That's just what happens when you're a kid. And I had all these infections, and I kept having pain every day, and they just told me to ignore it, and I would sprain my ankle and do this. every one of those things I just said causes immune activation and inflammation. And
Yeah.
that's so when they present to you or me, to use a kind of crude analogy, they're presenting after the glass is overflowed.
Right.
All right. So, and they were not well until their mono. They
That's right.
had a stage that was set that the mono then kicked off. Or
Yeah, I mean, you just reminded me. Last week I had a new patient, a woman in her 20s, and she gave a very clear history that she had gotten mono when she was in college, and then in high school, and then after her mono had resolved and she went back to school, and when she was in college, she was diagnosed with scoliosis, and she swears that she did not have scoliosis prior to mono. And I thought that was fascinating, and I had never thought of it along those lines. When you learn about scoliosis, of course, it's like this idiopathic.
Right.
It's something that just sort of happens as you grow during adolescence, and unless the degree is severe enough, there's not much you can do about it. They used to put these teenagers in the braces, or if it was severe, they would do surgery to correct it, and those surgeries are horrible and barbaric and painful. And but it occurred to me that these chronic infections and these severe infections affect the connective tissue so much that during a growth spurt, perhaps, is when that scoliosis is much more easily formed.
right.
And so I don't know, maybe you had thought of it before, but it was sort of like an epiphany to me about the vulnerability of connective tissue, certainly during early in life when we go through these growth stages, and it made me think about how important it is and how critical it would be to just sort of address these things very early in life if we can.
Right.
But it's such a hard thing to do. So
It's very
this
hard.
idea that you're saying that you're asking your patients about their children,
Right.
I think is so key and so amazing, frankly.
Well, thanks. But,
Kudos.
thank you. But in the question in that situation for the parent is, well, okay, what do they do?
Right.
It's
Right.
It's
I mean,
a real
that's always
challenge
what's left.
because,
Yeah.
first of all, as our subscribers know, most doctors don't really agree with us or think this way.
Right.
So I can just see them going back to their pediatrician, and they'll just roll their eyes and say you're nuts.
Right.
But I think it's a huge issue, and I want to see if we can. I keep throwing out the word inflammation, which is kind of everywhere. It's like that's
It's like detoxification.
It's the fed word of the decade. Okay, yes, it's like detoxification, exactly. But I do think it's true. And again, our brilliant colleague Andy Maxwell years ago, probably 3 or 4 years ago, put out this hypothesis about, well, what is really happening, and he went through how you have a mast cell and other inflammatory cells. I could label the cells, but there's lots of sources of inflammation in our body, and those cells, when they are activated, particularly mast cells, will release, as we've said, 1,000 chemicals, 1,000 molecules. Those molecules are very, very active, vasoactive and tissue active, including enzymes that degrade connective tissue. And he goes through the names of the different enzymes, and you really begin to see the connection, or it allows us to have a mechanistic connection to why inflammation causes connective tissue disorder. And then there was a paper, which I think I sent you, that came out pretty recently that was beautiful. It just showed this whole picture that he had described, but right down to the molecules and the cell. I mean, it was incredible. And I'll try to pull it and discuss it.
Yeah,
But
I don't think you did send it to
So
me.
this is not just you and me spouting off, oh, inflammation's bad, it's not good for your connective tissue. There are clear biologic mechanisms that can cause this problem. And like you just said, I have patients now who, in terms of your scoliosis story, who will say, I had a viral illness or I had COVID, and everything's looser. I can feel the difference. I can hear my neck more, and my arms feel loose. And I confess, if I had heard that 15 years ago, I'd say, I don't know, that's kind of weird. And now I totally believe it, and I understand why, or at least I understand the idea, the mechanism of why.
I agree, and I think we know that viral illnesses are behind a lot of flares for a lot of chronic illnesses. I mean, MS is a perfect example. I mean, MS, relapsing, remitting. When there's a relapse, the first question we ask is, were you recently ill? Did you recently have a URI? Did you recently have a vaccine? And it's because we know that again, a provocation of the immune system causes inflammation. I agree with you that inflammation is just sort of thrown around as sort of this wastebasket term, but it it's a real term. It's a real
Yeah.
physiologic phenomenon that happens in the body, and because there's a lot of these mediators that provoke an inflammatory response, which is, the influx of a lot of cells and fluid, and so there's swelling, and there's additional cells that are releasing certain enzymes that are breaking down tissue components, and so it's a real physiologic process inflammation is. And so when we use that term, there's real substance behind it, and we're not just saying it as
Right.
I think the world says
And to
it.
be clear, we would not survive as a species without acute
Right.
inflammatory responses.
Right.
I mean, that's the name of the game. That's what our
Absolutely.
immune system has evolved to do.
Right.
The problem is when that acute response either migrates into chronicity or is too powerful. And the tragic example with that is COVID
Mm-hmm.
and the cytokine storms and the tens of thousands of people that died in the early part of the epidemic because of these cytokine storms,
Yeah.
which was an over-inflammatory response acutely to an invasion.
Right. And so, one of the questions, of course, is why are some people so much, at greater risk or more susceptible to that chronic and that perpetual inflammatory cascade that
Right.
doesn't really seem to know how to stop, and why are some people more at risk to long COVID or even ME/CFS? When I think about, to use that same example, the MS patients, and there are other kinds of diseases that we can use as examples as well, they have an underlying chronic degenerative disorder that we consider degenerative. We consider it progressive, though many people remain stable on these newer drugs for longer periods of time. But regardless, we consider it a progressive disease. It's certainly nothing that seems to spontaneously resolve, let's put it that way. So there's an underlying chronic disease, and then they have a viral infection, then they have a flare, a relapse. And so I can't help but wonder, has there been, in these ME/CFS and long COVID patients, is there an underlying illness that just made them more at risk to this chronic inflammatory response? And is that underlying risk related to their connective tissue?
Right.
Right. And so what disease is that? What disorder is that? Which is why I've been so enamored in doing genetic kind of workups for my patients, because I'm trying to understand what made you more vulnerable than the person down the street.
Right.
Because there's got to be a reason. There's got to be a why.
I agree. And I mean, I think you and I have talked about this on the podcast before, and I know I've talked about it with other people and patients even. I think literally, with one exception, I've never met or taken care of a long COVID patient who didn't have a compelling early history of
Recurrent
what I would call
infection.
pathology that was not diagnosed as such because it wasn't disabling. It wasn't making them sick. And what I mean is, I got COVID and now I'm this way, doc. I never was sick before. And then you take a history and they describe a history that's, suggestive of mast cells, suggestive of connective tissue disorder, frequent infections, the whole picture,
Yeah.
right? But that was treated as sort of normal growing up. And I'm not saying it was wrong to say that. It becomes a kind of a noise, And then it seems to me that sets the stage for putting them at more at risk. It's a little harder to say that for the ME/CFS patients, although I think it's true, because when I meet them, they often have had their illness for 10 or 20 years. So it's kind of hard to sort that out from their early history. But I think your point is really important. You don't just catch chronic illness. You don't catch septeadness, right? It's a set of pathologies that develops in people who have a prior history of something going on that at the end of the day is chronically inflammatory and makes them more susceptible to the septed pathology picture.
Right.
And I'm sure there's genetics as the fundamental cause, but I'll be damned if I can figure that piece out.
I think that's why you have to do more genetics, because the more you do, the more you see, frankly.
Right.
And you start to pick up trends. And I start, in fact, that NOD2 variant, the Blau-Yao syndrome, whatever you want to call it, I see it
See it with
more than I would
RYR
expect
too.
to do it. RYR is another great one. I mean, so, and I'm not saying I know exactly how to interpret or even how to apply it, but the more I see it, the more intrigued I get and the more research I do. And sort of that's sort of been my whole career, basically, is that I pick up these trends and then I need to understand more why, so that I could be I could be ahead of the game for the next patient kind of thing.
Right. I agree.
So, and I agree with you. I mean, you do get a history early on, but it still doesn't give me a sense of like what was the underlying pathophysiology that was going on, other than obviously these septad diagnoses. But these are pieces of a puzzle, is the way I see it, especially when it's early in life. And unless there's a clear like connection that gives me a sense of a particular disease process. Like I feel sort of stuck sometimes, is what I'm saying.
Oh, I totally agree.
And then
totally agree.
I'm always trying to like connect the dots for patients. Like, so how do the mast cells contribute to the dysautonomia, for example? Or even the small fiber neuropathy, which I mean, I explain it well, and I have theories as to how, but I just want to understand more. I just want to know more.
Well, I mean, to say it another way, the same thing you're saying, slightly different perspective, is, those patients who, when you take their history, describe very frequent infections, ear infections, gastroenteritis, food reactions, all that stuff that we talk about.
Sensory overloads, we call it sensory integration disorder.
And if we believe, if it's accepted that those infections in that chronic inflammatory or intermittently elevated inflammatory state injures connective tissue, what is it about that phenomenon, the connective tissue injury, that then predisposes to this bigger septad type picture?
Right.
That's the thing I can't yet put together. And that's what it seems like to me. It's yes, some people are born with EDS. So let's put them on the side for a minute, okay? Because we have lots of patients who don't have that. They get so
at least none of the known subtypes, with the genetic variants,
that we can identify.
Right,
okay,
exactly.
So non-EDS, they get all these all the things we keep talking about, and then they end up as a septad. What is it about this chronic progressive injury to their connective tissue, which is what I think is happening, that leads them into all these other illnesses? And I can make up some reasons. We can talk about why POTS would occur and stuff like that. But there's a big black box there between childhood and...
Yeah, exactly. That's exactly what I'm referring to.
Yeah.
You said it a lot more eloquently than I did. I tend to ramble, I know. You're a lot more succinct than I am, which is why I appreciate talking to you. But I agree with you, and I want to make that clear to people who are listening to us that we don't have all the answers. Right. And one of the reasons why you and I have always sort of had discussions, and what led us to this podcast, is that this is what we try to explore together and try to come up with ideas of things that we could postulate and maybe even test for and look at. And because I want to have clarity on all of this. I want to be able to connect the dots in a lot more of a succinct manner than we have been able to. And even on our listserv, like I read some of the, not all the time, I don't keep up with it, but when I read them, I mean, it's clear that we don't have all the answers, because, someone will pose a question or will present a case, and there are like 10 different ideas and 10 different perspectives. And so I think it's important that we make it clear that we don't have all the answers yet, but we're certainly working towards that. But I do think that the chronic inflammatory response is a problem. We all are born with this endogenous stopgap. And with a chronic inflammatory response, we lose that stopgap. And some people refer to that as the cell danger response, of course. The cells sort of get stuck in this cycle of cell danger, and they don't know how to really come out of it. So it's like they don't know that the danger is gone, and that they can just sort of calm themselves down and not release their mediators that are inflammatory in nature, which many of them will break down not only connective tissue, but other components of our body. I mean, there are some that break down myelin, which is important for functioning of our central and peripheral nervous system. Right. So, and then what's interesting is that the breakdown products of the myelin in turn will then trigger a mast cell response. So again, it's these perpetual cycles. It becomes
a vicious cycle.
Right.
That's the problem. And when you migrate or move over to that position of chronic inflammation, all of the usual compensatory mechanisms, all of the homeostatic mechanisms that we have, which have kept us alive, are screwed up. I almost did a New York thing there.
That's okay. This is a safe space.
And again, I overuse this image, but I just find it helpful for me. Okay, it's the glass with water. Okay, so we are alive, and throughout our life, think of our inflammatory milieu as a glass of water. The glass is half full. We have an acute infection. It goes to 3/4, and then the compensatory mechanisms, the yin and the yang, kick in. It drops back down to a half or a third, up and down, up and down, up and down. And then something happens, maybe an accumulation of inflammatory events overlapping. Now it overflows. And once it's overflowed, the compensatory mechanisms can't put the water back in the glass. And then we're screwed. Then all of those homeostatic tools that are built into our body to lower immune activity become ineffective or less effective because the water just keeps coming out.
Right. That's a really important point, because I think when, a lot of patients and a lot of people talk about more, natural living and holistic, and I'm all about that, as you know. I did a lot of work in integrative neurology, a lot of work in integrative medicine, and I believe in our natural abilities to fight off and homeostatic mechanisms, and to harness our healing prowess. But I do think that at some point, and your analogy with the glass and the water,
Kaufman's glass,
is a perfect example. At some point, though, natural approaches aren't going to do the trick, right? And that's why, in our last podcast, we talked about immunosuppressant therapy. That's why I've become like such a advocate for some of these drugs, because I have found that to be one of the ways that we can really move the needle for some of these patients to get more to having the water back in the glass,
yes, exactly,
below the rim, where we can start to manage it maybe even more naturally.
That's really important, because I don't want to sound so negative. We can get patients better, all right, whether it's putting the water back in the glass or just putting a to-go cover on the glass. But, I mean, people can get better, but it's not easy. It's a lot of trial and error, and it does take, I think it takes drugs.
Yeah,
it also
does
takes
take
lifestyle
drugs.
change and all the other stuff we know.
Yeah,
but,
for sure.
Our patients are not going to most of the time get better without interventions of some kind. But I do think they can.
I know they can. We see it.
Yeah, I know. I mean,
happen.
I feel like I left a feeling that once the glass overflows, you're screwed, and I don't want to say that.
No, right. No, you're not screwed. There are still ways, but we're saying that it generally takes some drugs first, or in addition to, I should say, not instead of, but in addition to, and then at some point, we can wean the drugs and we can try a little bit more kinder, more benign kinds of approaches, and then, maybe focus in on just sort of lifestyle and more holistic, natural ways, of course. But I do think it's important that patients understand that sometimes we just really need to use drugs.
Right.
And the drugs can be important. So yes, but back to the immune system and EDS.
Right. We'll try.
Which we were sort of circling
did.
it. Yeah, I don't think we completely left it, because we were talking about the connective tissue part of it, of all this, of the immune response, which is an important point. Which again, in classic immunology, we never discussed connective tissue. I mean, it was not even on, like, it wasn't even in my syllabus. The connective tissue during my immunology, course in medical school. So, but we know that it's actually very much involved. It's very much affected by an immune response. And not only just from generalized inflammation, but there are specific enzymes that are released that target collagen types.
Exactly.
And I think that there are 27 different collagen types, some of which are fibrillar forming, which is sort of the primary structure of the connective tissue, but the extracellular matrix also holds a lot of different collagen types. And so some of these enzymes actually target certain collagen types. And so it's not only an indirect means of degrading the connective tissue with regards to inflammation, but also a direct means. Yeah. So it's an important point that I think we have not focused enough on, and I think we should. And the more I learn about connective tissue, the more I'm amazed at how critical it is to our body's functioning, to all physiologic mechanisms. I mean, it's not just sort of this mechanical, structural, static thing in our body. It holds a lot of physiologic phenomenon, not only immune presentation, but immune response, of course, to the presentation, but even innate immune activity, mast cells. I mean, there are a high concentration of mast cells that reside in the connective tissue.
The largest densities in our environmental interfaces.
Exactly.
Which is connective tissue.
That's exactly right. So a lot of mast cells and other innate cells. And so there's just a lot of immune activity, both innate and adaptive, that goes on within connective tissue. There's also within connective tissue, transfer and exchange of metabolites and nutrients and oxygen. There's waste removal. So there's a lot of activity that takes place that is super important for the way our body just in general works. And if the connective tissue is not doing its job, both physiologically, then clearly a lot of mechanisms are not going to be working as well. But even structurally, then our body is not held together as well. And then the organs don't really sort of know what to do, right? So, and I think that that's important that we don't focus enough on.
Well, I was going to say, I think that it's been a research desert for connective tissue.
Ooh, I like that term.
And I think it's basically because connective tissue up until now, perhaps, has not been sexy. Cardiology has gotten enormous cardiology has gotten enormous research. Atherosclerotic heart disease, enormous research. Infection, I mean, all these other things.
Yeah.
But I mean, you think about it. Before you started doing this kind of work, or I'll speak for myself, before I started doing this kind of work, I was a real busy doc, and I read constantly. I mean, I used to get paper journals, and they'd be stacked up on the walls and the shelves. I don't remember a single paper about connective tissue in terms of research, in terms of what goes into making it and harming it. It's just been a desert.
I agree.
So
I still don't see a lot.
No, you don't see a lot. We talk about it, but
right. And there's this special issue that I'm editing, for Frontiers in Neurology on connective tissue neurology, and we've gotten a couple of really fascinating manuscripts. So I think the tide is starting to turn.
Yes, I do.
But not it's not a big enough tide, and it's not a fast moving tide.
Right.
I agree.
And another example of how inadequate that work has been is, unless you're going to tell me something really surprising, is what the hell do we do for our connective tissue?
Yeah.
How do we fix it?
I don't know.
I mean, I have this conversation with my patients all the time, and I'm aware of, GHK copper and all this other stuff. But at the end of the day, I've yet to see a clinical trial of any kind, whether it's pilot, non-placebo, non-randomized, or a real deal RCT, that says if you do this, you can improve your connective tissue strength. You can reverse the tide. I mean, think about that.
Well, when you think about all the cells of the connective tissue, they are all of the mesenchymal cell lineage.
Yeah.
And so I fully believe in stem cells. Yeah. But there have been no trials to prove it because the FDA doesn't allow them.
Right.
And I think I've already mentioned previously that there is a group at Harvard that are working on stem cells for regeneration of connective tissue, in the Somite.ai, I think is the name of their group. But so people are looking at it, but they're all, there might be one or two. No, they're all of the mesenchymal cell lineage.
Right. But just to put that in this lack in perspective, this desert in perspective.
Yeah.
1 out of 5,000 people have hypermobility EDS, at least. That's the accepted. That's the written statistic. Right. If you look it up, 1 in 5,000. Right. I mean, so what is there? 350 million Americans. So I can't do the math in my head, but we're talking millions of people, and yet there's just a couple of startups in Boston that are doing this work.
Right. Yeah. There's actually also one at MIT.
It's pitiful.
It is pitiful. I agree. But it's got to start somewhere.
Yes.
I mean, and if you look at the history of medicine, this is how it goes, right?
Right.
So,
right. And I agree. I think it is starting. And I think it's starting in the research world and in the startup world or the entrepreneurial world, and starting with doctors like us and on the listserv. I think if you look at the listserv exchanges, there's so much that's discussed about what do we do, how do we fix this, what's it mean, how's it happening? And that's all new. So, I'm hopeful.
I'm hopeful as well. Yeah. I mean, sometimes I get excited over some of the work that's done because I really believe if we can figure out how to regenerate the connective tissue, I think it's about regeneration and not correction. It's just because it's just damaged and a lot of it is lost, and so a lot of it is not doing its structural and mechanical and supportive job. I want to make clear that obviously it's got a role of being supportive and being and buffering and helping facilitate movement, but along with that, like, again, if it's not doing that job, then even movement puts people at risk, right? So, subluxations and dislocations, those are the common complaints that you hear with EDS patients, of course. And it's really just about that connective tissue is not doing its supportive job. But it's also important to note that it's not just, a TARP. It is truly a physiologic living, breathing organ.
I mean, to put a more actionable light on this, okay? Because I was just complaining about lack of research, et cetera, and how do we fix it? It's clear that what we can do with our patients, and this would apply to anyone, not just our patients, is aggressively look for, diagnose, and manage those events that are causing inflammation.
Right.
Not acute inflammation. I mean, you want to have acute inflammation. You don't want to have chronic inflammation. And then you go ahead and you figure out how to manage it. And when I say figure it out, there are lots of ways. There's meds to quiet down mast cells. There's drugs to treat infections. There's meds to treat POTS. And every one of the I'll actually relate this back to another comment in the Patreon comments. Every aspect of septedness affects every other part of septedness, and it all causes inflammation. All right, because there was a person who asked about EDS. Why do doctors only talk about just EDS and not the other stuff? And that's the fault of of American medicine, or probably world medicine. We still think silo. We're trained silo. You just think about the heart here and the kidney there. Our argument is it's all related. And therefore, if you go after each of those inflammatory events and treat them, you may not heal the connective tissue, but you can halt the progressive injury to it. And I suspect you can help heal it. I mean, we have evolved to be these amazing organisms that can heal ourselves. And it's just a question of recognizing this. One of the, you know that I read a lot of the anti-aging literature and longevity literature, and I'm really spend a lot of time now taking that information and bringing it back to my doctor brain in terms of taking care of patients, because I think it's very relevant. All of the literature on aging and the diseases of aging, neurodegenerative diseases, atherosclerotic heart disease, et cetera, they all have the same conclusion. It's from chronic inflammation. And in that literature, in that world, there are a lot of things that people are doing to intervene on that. And I think all of that is translatable to our patients. It's a little bit of cowboy medicine at times, but I think it has to be looked at.
I completely 100% agree. And I do think that the immune response with its inflammation further worsens the problem with the connective tissue. And the more we can do to reduce that inflammation, and whether we take it from the longevity world, or we take it from the cancer world, or we take it from the transplantation world, we just take it and we reduce the inflammation for these patients so that we can protect the connective tissue as best as we can. And that, and we've talked about all those kinds of treatments, but I'm fully behind doing all of that in order to protect what's left of these patients in their connective tissue, to sort of maintain their body and their body's functioning, and to prevent, I think most importantly, to prevent further progression of disease. Because obviously I think you would agree that while we send a lot of patients for certain surgical interventions, because at some point you can't fix the anatomy with a bunch of drugs anyway, we try to prevent surgeries if we can, right? Because surgeries are not fun for patients in general. So we do a lot of anti-inflammatory work, and that runs the gamut, of course, of things that we can do.
And I think it's, ideally at any rate, it's not just a question of preserving what's left, okay, after injury. I do think that with aggressive interventions, patients can heal and get better, that their connective tissue can begin to recover. I mean, we mentioned vicious cycles before, so one of the most vicious cycles, is there a word, viciousest? No. Most vicious aspects of this cycle are our patients who cannot exercise, okay? So without getting into a rant about the value of exercise, I think most people would agree that when you exercise, you are improving muscle function and muscle strength, but you're also improving bone health, and then a dozen other things, okay? And so our poor patients are so screwed because they can't exercise because of their post-exertional malaise and other problems. And it's kind of like salt in the wound. Was that the expression? Salt in the wound?
Yeah.
It's bad enough that they're so sick, but one of the things that might help them the most, exercise, they can't do because of the nature of their illness. And one of the things I've been thinking about a lot with patients recently is, how can I is there a way I can discuss beginning some sort of exercise program without suddenly sounding like I'm one of those horrible doctors that say, "Oh, just go out and exercise."
Yeah.
It's a
No,
narrow
I
line to
totally
walk.
understand that.
But
I mean,
I
a
think
lot.
it's a key piece.
It is a key piece in a couple of things. I mean, I remember, years ago learning that too much exercise was not a good thing. And I was reading because a lot of these, marathoners or elite athletes had higher levels of reactive oxygen species, and it was thought that too much exercise can actually be damaging because of all the free radicals that are formed. And I think that our patients are so chronically ill that even the slightest amount of exercise is too much for them, along that same concern.
Right.
And so it started to make sense a little bit to me about why they can't exercise and why it causes the PEM and the crashes. And the other thing, now I'm forgetting my second point. Oh, and I completely sympathize with that idea of, like, you want to try to help your patient do even a little bit of exercise without sounding like a doctor who doesn't understand that they can exercise, because you sort of struggle with the idea that how important some exercise is. So you're trying to find a way to get them to do that, because in writing the book that I'm writing, I have this whole chapter on movement, and I was so stressed out over how I was writing it, because I knew that someone was going to just sort of complain that I was saying that you should exercise when I should know that you can't exercise, right?
Exactly.
So it's a very, like, uncomfortable place to be as a doctor to my patients who are chronically ill, who I recognize can exercise, because my goal is to find a way where you can just a little bit, because I know how important it could be and how helpful it can be. And so it's a hard, like,
it's very difficult.
Yeah, it's a struggle.
It's I have the same problem when I suggest to patients that they do explore or do some of the neuroplasticity programs like DNRS and Gupta, because I'm afraid as soon as it comes out of my mouth, they're going to think, "Oh, another doc, he thinks it's all in my head.
Right, exactly.
He's an idiot. I'm out of here." And I'm obviously don't think that.
Right.
But I get nervous every time I start to bring that up.
No, that is so true. Sometimes, I mean, I do think that there's a PTSD that's associated with just being chronically ill.
Yes,
And
exactly.
I've often said to patients,
Oh, yeah.
we're gonna work to get you better, but at some point we're gonna have to address the PTSD component
medical
of this.
PTSD with very good reason.
Lots of good reason. I mean, not only from their experiences with other doctors and being gaslit, but also just the change of their lives, right? The quality of life is gone, and their previous lives have been upended, and there's a mourning that's associated with that, and a grief, and that can result in a certain type of PTSD that eventually has to be grappled with, because it'll just carry with them throughout the rest of their lives. So, and so I try to bring that up, at certain points along the way of my care with them, in ways that they understand that I'm not suggesting this is in their head, but there is this component of it that we're going to have to eventually deal with.
Well, yeah, and our brains are totally connected to our bodies. If
it's like that
every
song.
week there's articles that come out on this, so it's not. Yes, it is in your head, but that's not a negative.
It's not.
It's used as a negative, unfortunately, by mainstream, but it is not a negative, and it's true. I want to go back to movement since you're writing this book. Really going to go wildly off topic here. So what do you think, since our patients can't exercise in even a zone 1, 2, just a little, the use of vibration plates, and does that injure their connective
That's a really
tissue?
good question.
I have a patient who I initially was not, I thought it was risky because of connective tissue problems, but there is a device whose name I'm at the moment blanking on that claims that they've done research to show it can help, and I have a patient who purchased one of these and thinks it's been helpful. Do you have any information?
I think it's I mean, I do actually. I researched it a little bit, and there isn't a whole lot of research on vibration plates, just to put that out there. But I think it's actually individual to the patient, depending upon their state of inflammation, their state of disease. I mean, if there's active infection, I would avoid it for that time being. If those chronic infections have been treated for a period of time, and there's evidence that there's some improvement in inflammatory markers, for example, or even in the testing of infectious organisms, that the antibodies have come down, or whatever markers you use, that you can reliably say that the infection has been treated appropriately. I think that they're actually a great idea, frankly.
Because they're activating the muscles
Exactly.
in a way that doesn't
use your
It's
energy.
passive, right?
Yeah, it's passive.
Yeah,
That's the
no,
word.
for
Thank you.
sure.
That's the
And
word.
that's important. And even when you think about POTS, for example, I mean, one of the reasons why humans are so susceptible to POTS is because we need lower extremity strength and pumping to
Right.
move, blood back up for the preload to the heart. And without the ability to do that, we're at risk of something like postural orthostatic tachycardia syndrome. And so, and it's also the point behind the tilt table, right? So we just sort of we remove the ability to use our leg muscles to pump fluid back up, and so they're just sort of tied down to the table, and you can't do anything with them. So that's why I say though, when patients are in the throes of chronic illness and are in truly an inflamed state, I worry that the vibration itself can actually further break down an already inflamed connective tissue layers. But if they have been treated and are somewhat better, I think this passive movement of the muscles, the passive recruitment of the muscles, can actually be very helpful.
Yeah. I mean, you bring up another point there, or maybe you didn't intend to, but I'm going to make it. And again, this gets back to the vicious cycle issue. So we both have a significant percentage of patients who are essentially bedbound, most of the time. In one way, you can say, and patients don't like to hear this, nothing could be worse for your POTS than to be bedbound, right? Because those compensatory reflexes, the hemodynamic reflexes, atrophy very quickly. That's why patients who go in for a gallbladder surgery and they're in bed for 2 days, when they stand up, they faint. It's because in 2 days, the vasoconstrictive reflexes have atrophied, okay? So you have these poor patients who are stuck in bed, and it's like, it just accumulates more and more difficulty in recovery. And yet, what do? I can't say get out of bed. So I try to say, well, sit up in bed. Right. Sit up in bed. You stay in bed, but at least sit up, because that will activate some of this stuff. Or sit up in bed and hang your legs over the side, even for 1 minute a day, gradually, to get these reflexes back in shape. So I wonder if that vibration idea would be useful actually in bed.
It would be, but how would you do that? I mean, like a vibrating bed?
Yeah, well, they make those massage vibrating beds, but I don't know what they're like.
Wait, they do? I've never seen one. Okay. I mean,
I've
seen the plates.
I've seen them in the movies, little coin machines.
What movies are you watching?
Old movies. But it shouldn't be difficult to do. I have no idea if it would help.
I think it would help, but again,
I mean, the bottom line is we know that
the nice thing about the plates is they have bars that you can hold on to.
Right.
So, if a patient is able to stand, then I think it could be useful for like a few minutes at a time. If that even, they just start and they can just sort of work their way up into longer periods of time if they could. But yeah, I think that if a vibrating bed, I don't think it would be, I don't know. It just sounds weird to me. I'm thinking about those little horses like that used to be in front of like the Walmarts when I was a kid.
And Woolworths.
My mother would, Woolworths. Oh my God. I hadn't thought of Woolworths.
Now I'm showing my age. Woolworths.
My mother used to put me on one of those horses and put a quarter in.
Right.
And
There's probably a dime then.
That was just a dime. Or maybe, I think it was actually a nickel.
Right.
God, I'm old. All right. So.
All right. Well, we got a little off topic.
But I think it was a good topic.
Yeah. Anyhow, the bottom line here, in terms of the person who asked us to discuss it, EDS and immune system are like that.
Yes.
Okay?
Absolutely.
And it's something to not forget for a moment every day in terms of managing yourself and working with your physicians or your healthcare people. So
for sure.
I hope we didn't confuse the hell out of everybody today. It's pretty obvious that we don't rehearse. When you think of, I think Eileen and I were texting last night at about 10 o'clock. What should we talk about today?
Because there's so many topics to choose from that we just sort of pick at the last minute. So I hope that this was helpful. Thank you for listening. Please tell your friends, your family, your dog, definitely your doctors. We want to obviously educate other doctors so that our patients can get more help from others. And we want to sort of spread the word. So thanks for being a supporter and a subscriber, and we will see you next time. Bye.
Thank you.